Hello, everyone, and thanks for joining this exciting webinar today, which I'm very honored to moderate. I have chosen excellent guests, excellent talkers for this exciting topic. And this meeting is organized by two companies which have products which I really like. One product is, of course, the OpenNC balloon, and one product is the SELUTION. And interesting enough, they decided to join and do this together, and this is really great. So I'm very honored to have such a fantastic faculty for this meeting. We will start with Dr. John Shulze, who is a great engineer, and he has been really involved in many different technologies, and to mention just some of them, he developed the first biodegradable polymer for drug-eluting stents, and he will show us some technical details about drug-eluting balloons. And then we will continue with myself. I will try to explain why preparing a lesion well is important, and how to prepare it well when you try to use a drug-eluting balloon. So rather educative way of explaining why this could make sense, what we are doing. And then we will have Dr. Bossard, my good friend and co-worker in the hospital in Lucerne, who will speak about chronic total occlusions and drug-eluting balloons, which is a very emerging new way of treating CTOs, something we maybe didn't think about just some years ago. Then my good friend from Poland, which I always meet in Krakow, but I haven't been there now for some years. I hope to join you this year again live. And he will speak about coronary bifurcations and the use of drug-eluting balloons in this indication. Very interesting topic. Going away from two stents, maybe going to two balloons for bifurcations. Let's see what he's going to show us. And then last but not least, we will have Dr. SUDHIR RATHORE, who will speak also about using of DEB in complex coronary bifurcation lesions. So interesting faculty, and let's start with John. John, welcome to this exciting environment here, and let's hear what you are going to teach and tell us about drug-eluting balloons.
Thank you, Florim. Let me put up my slides. So good morning or good afternoon, everyone. I'm privileged to be here speaking about, to tell you about the SELUTION sustained Limus release drug-coated balloon, a relatively new technology that has been developed by Med-Alliance. I think the first thing that we like to mention is that what is the potential advantage? Why would you consider using drug-coated balloon in coronary applications as compared to using a drug-eluting stent? As you know, and I've been involved with drug-eluting stents for so many years, and we know they work extremely well in coronary disease. But there are still a few aspects of stents that are problematic. As we know, after we implant stents in the coronary tree, there's an ongoing average 2% per year risk of stent-related events that relate to thrombosis and also recurrence of restenosis. So in relatively younger patients, the chances of having an additional procedure some years out after implanting the stent are relatively high. This is a paper published by Greg Stone recently that did a pooled analysis of 25,000 patients in 19 stent randomized trials showing this ongoing risk. And I think we have the opportunity to reduce long-term events by treating some lesions with drug-eluting balloons as compared to stents, especially in small vessels, complex lesions, diffuse disease, and a topic of today's discussions, bifurcations. So we think there's a potential developing new paradigm of in a large number of coronary patients where we can actually preserve arterial physiology, in other words, vasomotion, by applying a drug-coated balloon instead of a stent scaffold, which will allow for positive remodeling and avoid scaffold complications such as inflammation, wrong use of dual antiplatelet therapy, a potential for stent fracture, and in some cases avoiding a full metal jacket. So using a drug-coated balloon can keep the patient open for future interventional procedures more readily than a stent. So as you know, if you're working in the coronary space, sirolimus has largely replaced paclitaxel as an anti-restenotic drug because it's a cytostatic drug. It has a wide margin of safety. But most importantly, the late loss, lower late lumen loss, the anti-restenotic efficiency of sirolimus has been established in coronary trials to just be better than the use of paclitaxel. So you can see here some of the trials that have been done that established that sirolimus stents were better than paclitaxel in the field of drug-eluting stents. So our goal with designing a sirolimus-eluting balloon was to enhance tissue absorption, because sirolimus is not as readily absorbed into tissue as some of the other anti-restenotic agents like paclitaxel. And so we had to develop some kind of a way of applying, if you will, an instant glue that would allow the drug to be adhered to the vessel wall during this relatively short procedure involved in deploying a drug-coating balloon. We wanted to extend the tissue retention time, because we knew in order to allow sirolimus to really be effective, we had to have a pharmacokinetic profile that was at least comparable with what we get when we implant a drug-eluting stent. And as we know, drug-eluting stents, the coatings are capable of releasing the sirolimus over a 30 to 60-day period in order to exert the anti-restenotic effect. If we just coat sirolimus on a balloon without some kind of a time release mechanism, we would have a very poor result. You need an extended release of the drug in order to have to cover the entire anti-restenotic cascade. And finally, we wanted to use a non-crystalline form of sirolimus, because the crystals tend to be very rough. The surface of the balloon becomes quite irregular. It makes the balloon tracking much more difficult. It does more injury to the vessel wall. And there's a lot more potential for wash-off and embolization of the drug when you're using some of these first-generation coatings, such as a contrast medium to really apply the drug. So we really required the development of a whole new coating system, which we call a cat membrane, which I'll talk more about. So the first step was to combine the sirolimus with the biodegradable polymer, very, very similar to what you would find on the surface of a drug-eluting stent that contains a biodegradable coating. And this took the form of these small microspheres that you see on the right-hand panel. They're 4 microns in diameter, and there's literally millions of them that are created and placed on the surface of the balloon, each one of them comprising a miniaturized drug delivery system that's capable of releasing drugs over a 60 to 90-day period. That is then combined, the microreservoirs are bathed in a cell-adherent technology. This is an absorption enhancer, which increases the delivery efficiency of the sirolimus into cell membranes, which is based on amphipathic lipid technology, which was developed by Metalliance specifically for a new generation of drug-coated balloons. And then this is just a movie showing you the animation of how the combined system works with the microreservoirs, the biodegradable polymer and drug, combined with the cat coating, which enhances the delivery. As we expand the balloon, the cat coating carries the microreservoirs to the vessel wall, where they're able to be embedded and released over a period of up to 90 days. This is basically different than you find with other drug-coated balloons that are using relatively less sophisticated coatings that are basically burst release application of the drug. So in this example, compared to some drug-coated balloons that were developed for the vascular treatment of vascular disease. You can see that on the left panel, we have a much longer drug release out to 60 days, still maintaining adequate therapeutic effect in this animal model. You see on the left, compared to the other systems where the drug is relatively lost over a 28 to 30-day period. And then, of course, we can, because of the relatively constant release of drug, we can actually go to a much lower dose of drug overall, because the importance is the timing and the release of the drug, the pharmacokinetic profile, not necessarily releasing a large amount of drug early, because when you release large amounts of drug, it's just lost to the interstices between cells. There's only a certain number of drug molecules that can reach inside and reversibly bind to the immunophilins that are actually playing a role in cell multiplication. So here's just some pictures of a coronary pig artery that's been implanted with a sirolimus-eluting balloon, the solution. And you can see these colonies of microspheres that are actually inhabiting the surface of the vessel wall, where they continue to release drug and biodegrade over a 60 to 90-day period. So here's the drug concentration pharmacokinetic profile. And what I want to point out to you in the green is the actual pharmacokinetics of solution is very close to what you would get with a currently available, commercially available drug-eluting stent. So our goal is to get a pharmacokinetic profile that we also see when we implant a highly clinically successful drug-coated stent like the Xience. So in essence, you get the same pharmacokinetics as you get with the Xience stent, but without the metal scaffold. This is quite a bit better than you see with other competing sirolimus-eluting balloons that are available today. So why does sustained release really matter? Well, it all has to do with the restenotic cascade, which was actually published by Forster back in 1991. When you do angioplasty, first you get a platelet deposition in the injured area, followed by inflammatory cell recruitment over a 1 week, 3-day to 1 week period of time. And then you get the actual smooth muscle cell activation and proliferation into the area of the angioplasty. And finally, you get matrix formation, which actually lasts for an extended period of time after you've done your interventional procedure. And so we really need to have drug release over this entire period, not just over the first 30 days, to have the best effect on controlling restenosis. So this is just a picture of what happens in the peripheral arteries, where actually the healing process is even longer. And so in other applications where drug-coated balloons are being used, we also need a very extended release of the drug in order to deal with the smooth muscle cell proliferation and the ECM formation that goes on for extended periods. You may recall the Endeavor stent, which was a Limus-coated stent which was unsuccessful in terms of controlling restenosis. And you can see the pharmacokinetic profile of Endeavor was just too fast. And that's why it did not continue to provide an extended release of drug over an adequate period of time to really treat the entire anti-restenotic cascade as described by Forster. Whereas the more successful clinical designs of drug-eluting stents today have an extended release that lasts at least 30 days. In the case of a stent that I designed, the Myomatrix, the release that lasts up to 90 days. And it's been a very successful design going out and treating patients. So the microreservoir technology produces a coating which is very smooth and supple. And I think this is one of the very important side advantages of using these new lipid-based coatings that we use on solution. It doesn't create these large flaking particles that can go downstream and embolize into the downstream coronary vascular beds. And this results in an absence of this phenomenon that we often see, which is called slow flow, where you see of these large particles going down and actually being trapped in vascular beds and causing some changes in downstream coronary pathology as a result of the presence of these large particles. So I'm just going to interest in the time saying that microreservoir technology is extensively used in other areas for delivering drugs that need extended release in other applications such as cancer. And it actually improves the drug stability in an aqueous environment, and it shields the drug from being washed away during delivery to the target tissue. And it's often used with highly toxic drugs that need to be released slowly. So microreservoir technology, as we've now first applied in drug-coated balloons, is not a new science. It's actually been well established in other applications. And I'm going to just move on and say that I think the coating technology that we're using is better, and I think more companies will be moving to these lipid-based coatings. So the solution SLR was first tested in coronary in a solution SLR first-in-man trial, which was reported by Dr. Windecker at the European College meeting. The objective of the trial was just to show that the sirolimus as delivered by the balloon was efficacious with short depth of 1 month, and looking for all the secondary safety endpoints at 6 and 12 months for freedom from TLR and TVR. Lesion types were large preponderance of small vessel, 24%, 31% bifurcations, 4% CTOs, and importantly, 84% of these in this first-in-man trial were de novo lesions, 16% were ISR. There were no deaths or MIs through 30 days and 1 TLR at 6 months in this first-in-man study. So the primary endpoint was met of freedom from device and procedure-related mortality through 30 days. If you look at the Kaplan-Meier curve for late lumen loss, we had a very acceptable performance. At follow-up, the Kaplan-Meier weight loss figures were very close to the results that were attained post-procedure, and much better than the pre-existing diameter of the vessel. Here's also the diameter stenosis. I've seen pre-67%, dropping to 22% post-procedure and 30.5% at 6-month follow-up. In terms of mean late loss, we can see a very nice distribution of low late loss, the average being 0.26. And we had one outlier, which had to do with a lesion that was treated with both paclitaxel and sirolimus, which created the TLR. We're not sure why both kinds of drug-coated balloons were used, but ended up not being a good solution for this particular patient. So we're continuing with our studies. We know more data is needed with the solution first-in-man trial. It's a de novo trial in Asia, which has been completed at 12-month follow-up. We are looking at longer time periods. The solution ISR is a FDA trial to look at using sirolimus drug-coated balloon in the setting of in-stent restenosis. The solution de novo, which is a large trial, 3,300 and some patients in both Asia and Europe, which we're very excited about because we think that drug-coated can replace drug-eluting stents in the coronary de novo applications. And finally, there's a similar trial with the FDA, which is an international trial in Europe and the US that is being reviewed by FDA currently. So we hope you'll learn more about the unique technology embodied in the solution drug-eluting balloon through the following talks. I'm excited to be part of this presentation, and I'm going to turn it back to the moderator and the other speakers to talk about some of the specific applications that they're excited about. Thank you very much for your time.
Thank you, John. Very interesting. Before we move to maybe questions from my colleagues here, I have one very technical question. You know, sometimes the balloon does not cross. and then you have to come back and then push again, and then come back and push again. How much drug do we use if we have difficulty in delivering the balloon to the target lesion with a solution now specifically?
So with drug-coated balloons, and this comment is general to all drug-coated balloons, if you have significant difficulties delivering to the lesion, in other words, the lesion is tight or highly tortuous, and you're not able to deliver it within a time period of several minutes, I would recommend taking a new drug-coated balloon. The coating on the solution is relatively robust. We've done a lot of testing to make sure that it's not easily dislodged. And I think it's one of the better coatings in that regard, but there is certainly potential for scraping off the coating in the presence of a lot of calcium, a lot of tortuosity. So I think if you incur a lot of difficulty and you can't deliver it in a certain time period, it's not because the coating is washing off, but certainly mechanical disturbance of the coating is possible.
Okay, thanks. So are there any questions from the faculty, from the presenters?
There's one more question from my side regarding the coating. How do you do it? You basically inflate the balloon and then coat it and then deflate it and fold it, or do you have a folded balloon which gets coated?
Yeah, it's inflated so that the entire surface of the balloon is exposed, and then it's put into a fixture that rotates, and we coat the entire balloon. So the folds are also coated inside. Excuse me.
I would like to comment only that you stressed two weakest points of the drug-coated balloons in your technology. One is drug loss during the delivery. And we know that there are many balloons from the leaders of the drug-eluting balloon technology that you can lose as high as 80% of the drug during delivery. So it is you are delivering just little something in the end. And as Florim said, even if you have additional difficulties in delivering the balloon, you are delivering just the plain balloon. That's the most important, I think. And the second thing that is, in my opinion, the breakthrough is the long-lasting release of the drug in the place of angioplasty or in the place of damage, because that's what we believed up to now. We believed that we should give small dose or big dose of the drug, but for the short period of time, because we believe that, we should stop the proliferation of the smooth muscle cells to prevent restenosis, but we haven't, we cannot stop the endothelization of the place of angioplasty because it gives, it also stops the proliferation of smooth muscle cells through the release of the nitric oxide. So this is breakthrough of the technology, because you are giving the long-lasting, small amount long-lasting of the drug, which goes to the smooth muscle cells, not stopping the proliferation of endothelium. So can you comment on that?
Yeah, so we learned well from our 30 years experience with drug-eluting stents that the drug-eluting stents endothelialize more slowly as compared to a non-coated scaffold, because the presence of the drug actually slows down the repair mechanisms that are natural to the artery. The drugs, whether it's sirolimus or paclitaxel, do slow down endothelialization. They do slow down at the same time that they're preventing smooth muscle cells from proliferating. So these drugs act on both endothelium and on the smooth muscle cells. So Sirolimus in that regard seems to endothelialize better because it's less toxic, but there's still some slower action. So that's why it's important during that initial period of, I would say, at least 30 days to still have some kind of antiplatelet therapy on board, because we're slowing down the repair of the vessel by using drugs.
Okay,
So
thank you very much.
let's try to move forward to be in time. So now I will continue with my talk, and I hope I will generate some discussions within the spectators. And of course, I'm very keen to know what Professor Bartusś and Dr. RATHORE think about this. So, cut and crack. Maybe you have read it on LinkedIn already. So cut and crack and drug-eluting balloon. This is the way we are treating our patients in Lucerne. First, before we talk about cut and crack, I think we always need to speak about lesion preparation and speak why PCI fails. And of course, then I will show you some cases and then we can have a discussion about that. This is an old slide which I really like to show because I think before we speak about different drugs, if it's sirolimus or paclitaxel, which is important, we have to speak about mechanics. And PCI fails when you have a chronic total occlusion and you treat it, when you have a long lesion, when you have a small diameter, and when you have an instant restenosis. This is the topic which we have to address. And besides diabetes, all the factors are mechanical, and this hasn't really changed in the last 20 more years. We learned how to implant stents and how to prepare the lesion when we did this study, which was a study which unfortunately did not receive a lot of attention. Because also the design could have been better. But what we saw here, this is just briefly, we did a study where we randomized 50 to 50 patients, semi-compliant or non-compliant balloon for lesion preparation. And we did OCT after stent implantation, and you can see here the difference was not really significant. So independently, if you pre-dilated with a non-compliant or semi-compliant balloon, when you implant a stent, the difference was not really major. But then when you post-dilated, you see that you achieve a significant difference. So the patients who were pre-treated with a non-compliant balloon benefited from post-dilatation, but only those really benefited who were pre-treated with a non-compliant balloon, but not those who were pre-treated with a semi-compliant balloon. So lesion preparation pays off, and this study basically demonstrated that you have to do aggressive lesion preparation and good post-dilatation in order to achieve optimal stent expansion. The problem is that when we use drug-eluting balloons, we don't really have the chance to do post-dilatation. So we have to even take more care about lesion preparation. And that's why I showed this slide. Now, when you do lesion preparation and you have a calcified lesion, like in this case, which is really not a very thick calcium ring you see here, but if you use the wrong balloon, then you will dissect the vessel, and your dream of putting a drug-eluting balloon will end up because you will need a stent to cover this. Now, how did we learn to combine cutting balloon and non-compliant or highly non-compliant balloon like the OPN in our hospital? We learned to combine this with a calcified lesion, and this was about 2 years ago. We had just discovered the Wolverine cutting balloon. We had a lot of experience with the OPN balloon for many years. So this was not a very difficult lesion, but I felt that when I looked at this, I said, why don't we just combine cut and crack in this case? And this was the lesion. As you can see here, it's highly calcified. with a bit of aneurysmatic bits, we thought, and then you see the second part, also very highly calcified. Now, back then, I would not have even dreamed of treating this lesion with a drug-eluting balloon, I have to say, because it's highly calcified, and I thought I need a stent, and I even putting a stent, I said I really need to do this very, very well. As you can see here the calcium, and then I used a 3.0 balloon cutting, a Wolverine, a 3.5 NC balloon, OPN at 30 atmospheres. Then I put 2 stents and post-dilated. Now, what I saw here is that the effect of the cutting balloon was actually impressive. The calcium in this case was not very thick. And I said, aha, I can cut the calcium and then I can maybe flatten it with a non-compliant balloon, with a highly non-compliant balloon. So I thought, oh, this is actually good. With one, I can prepare the lesion just halfway, and then with the other balloon, with the open NC, I can really create lumen. So this was basically the birth of the idea to use this principle for drug-eluting balloons. In this patient, as you can see, the result was good with a stent, and he hasn't come back now for 2 years. So I hope he's still doing fine because it looks good. And as you can see also, it looks good on OCT, but we put a very long stent. This was something Dr. Bossard would call a longo in our hospital because it's a long stent. Now, why do I believe, or do we believe, that it is a good idea to combine cutting and cracking with drug-eluting balloon? I think it's good for many reasons. One, I said it's the mechanical part of it. So I believe, or the experience we have made so far, is that when we combine it this way, and I will show you cases, that then the lesion is less likely to dissect. I was moderating a case of Dr. Colombo yesterday, for whom I have big respect, but he was using semi-compliant balloons at high pressure to do lesion preparation, which surprised me a lot, because then the artery was completely dissected. Of course, Colombo can afford to leave it just like that with many dissections and not put a stent, but only Colombo can afford that, not Dr. Cuculi in Lucerne. So our philosophy is really to cut first with a rather undersized Wolverine, and then crack it with a bigger OPNC balloon, but with less pressure. So we do the opposite what we do in calcified lesions when we go, where I say use downsize the diameter of the balloon and upsize the pressure to crack the calcium. In this setting, we do the different. So we use appropriately sized OPN balloon to create lumen, and we use a rather undersized balloon to really cut it and use it at high pressure. Now, this is a bifurcation case, but it's a very interesting one, because as you can see, this is a LED diagonal bifurcation, and it's a bifurcation which you usually could find a lot of people who would put 2 stents here. The problem is the patient is 38. So this patient is 38. We diagnosed this on CT. As you can see, he has some coronary disease, also the left main, which we did IVUS, and it was fine. So how do we treat this LED diagonal bifurcation? Here another picture. So it's clearly significant. The patient has symptoms. We have to treat it. But do we really want to put a stent in a 38-year-old man? Now, how did I treat? I used a 3.25 Wolverine balloon at 25 atmospheres. And then I did OCT. And as you can see, and I will show you the full OCT run, and the vessel in the distal bit, this is now the OCT after using a 3.25 balloon. As you can see, the vessel distally looks pretty okay. And now we are coming to the interesting bit, and you will see what you always see when you do intravascular imaging with OCT, you will see a dissection. And you see it here. And what you also can see is, although if we use a 3.25 balloon, the lumen is still not very large. So now putting a balloon like a solution here, and yes, you can see angiographically as well, it's really not, it's not there yet. It's much better than in the beginning. The patient might be symptom-free. Colombo would do a FFR and see it's fine, but I was not happy. I want to be not better than Colombo, but better for the patient. So what we did here, I continued with a 3.5 OPN balloon, and I went to 26 atmospheres, which is rather high, but the lesion was not inflating. And I said, it's a young man, I want to have a good result. If it works with a balloon, yes, fine. Otherwise, I'll put a stent. And then I had to take care, of course, about this diagonal, because as soon as I pressed the LED, the diagonal was insulted. Then I went into the diagonal. I opened it up with a small balloon, used a 2.0 solution balloon for the diagonal, to be, but did not intend to kiss. And I said, I will make a compromise maybe on the diagonal rather than the LED. And then I used the 3520 solution balloon for the LED, which I inflated really at 4 or 5 atmospheres, very low pressure, because it's a semi-compliant balloon. I don't want to dissect the vessel. Now, this is the result on OCT, the final result. And as you can see, also angiographically, the LED has become bigger. Let's just go here. Yes, the LED has become bigger, and now we are coming in this region of the LED, and I'll stop it here. Now, of course, you will see a dissection here, but it's not a really major dissection, I felt. So we left it as it is. Here, you can see what was the difference between the lesion when I used just a Wolverine balloon 325, and then the luminal gain you achieve with the opium balloon 3.5, which I went to very high pressure. You can see the luminal gain is massive, with just 0.25 more of diameter and a different balloon. And I think this is a very important message. Balloon choice matters. It's not, I'm fed up of hearing people say, well, it's always all balloons are the same. Well, no, they are not. They are not. Lesion preparation, you should really know your balloons and then how to apply them. Now, this is what it looked like angiographically at the end of the procedure. You can see the LED does not look perfect at that region, but I felt it's okay. Now, if I insist, then I will dissect it, and then I will have to use a stent. And I wanted to bring the patient back, and I brought him back after 3 months. And this is what it looks like after 3 months. So you can see the LED is patent. It looks even a little bit better than in the initial angiogram. And from our experience, and we are now using SELUTION since about 1 year or so, is that if your initial result is good and your short-term follow-up is good, usually it stays good. And this is what we are learning now. So this is the final result. Now, Matthias will speak, Dr. Possart will speak about CTOs, but with the same principle. This is a different patient with a CTO of the circumflex, which we treated with cut and crack with a 2.5 opium balloon and a 2.5 cutting balloon and a 3.0 opium balloon. And as you can see, and then the drug-eluting balloons were 2.5 and 3.0, so rather conservative as well, and very low pressure. And you can see after 6 months, it looks good. So if it looks good acutely, then usually it stays good. So I think lesion preparation is still a matter of discussion. And I think it's still a matter of discussion even for drug-eluting stents, because everyone is doing differently and we don't really have guidance for this. And this is a bit something which is a pity, because it's such an important matter and we have guidance for everything else, but we have no guidance for lesion preparation. However, I think for drug-eluting balloons, it's even more open, because nobody really knows how to prepare the lesion well in order to achieve a good result in the short and long term. And then the second is cut and crack has allowed us to treat more patients with drug-eluting balloons in Lucerne, and we have really our number of or percentage of drug-eluting balloons usage has increased massively. And I think one of the reasons for that is because we have learned, we have always had the idea to use drug-eluting balloons, but using the appropriate approach to do lesion preparation is what has changed, or what has enabled us to use it more. And in our experience with the SELUTION SLR, I think the results are promising also in the long term. And we are glad that one of our abstracts with our all-comers population was accepted DCT, and Dr. Bossard will present this very soon, and hopefully live in where is it? I don't know, in San Diego or so. Let's see. Okay, thank you very much for your attention, and maybe we have some questions from your side.
Thank you, Florim, for this beautiful presentation. What you showed is just coming back to the origin of the interventional cardiology, to the plain balloon angioplasty. However, you showed clearly how to control the most important problem of the angioplasty, how to control the dissection. And this is how you showed how to cut the artery and then open it widely. And this is always what we called in the previous 10 years, 20 years ago, a stent-like result. So this is, because 20 years ago, I can remember we had only Palmas shot stents that we had to cut with the scissors, and that was one stent for 2 people. However, we always tried to use the long inflations of the balloons to heal the dissection or to control the dissection with first with a small inflation, with low pressure, then higher. And then we learned from IVUS that we should use bigger balloons to open widely the artery to get the better results without stent. So this is a great concept. Congratulations. This is the fascinating concept for me.
Thanks a lot. Maybe some other comments?
Brief question. It was a great presentation. In your experience, what is the ballpark figure in terms of flow limiting dissection? Because we are sometimes worried when we use Wolverine cutting balloon, we don't seem to go at very high pressure, and you seem to be applying high pressure as well. So in your experience, what is the risk? Because obviously we're trying to limit the dissection, and at the same time we want to do one-to-one dilatation of the lesion to provide better results with the drug-eluting balloon.
Well, I think it's very important that I think the lesion needs to be cracked. If you don't crack the lesion, then you will. It's useless to use a balloon or a stent, because then it's not, the result long term is not going to be good. So what we are trying to achieve, and I really do this, and you will hear from Dr. Bossard, because we are. You won't find a second place in Switzerland discussing so much about lesion preparation and how to prepare. So you can imagine, it takes sometimes 20 minutes before we decide which balloon to use, because we discussed how the size, and this is it's done with a lot of love, I would say. So what I think with the Wolverine balloon, it's important not to oversize the balloon. If you oversize the balloon, then you will dissect even with a lower pressure. However, we try to have the balloon open, and we try to have angiographically an appropriate result so that we have the feeling the lesion is cracked. The lesion does not have to be perfect after the Wolverine, because we are doing this with the OPN balloon. And with the OPN, then we go with size and try to gain lumen. So with the Wolverine balloon, we are trying to really just prepare the lesion for the OPN. And the second interesting effect, which I did not mention in my presentation, which we cannot prove, but I think by creating a bit of dissections, and you always have dissections, you will have dissection even with other balloons. We try to create those scripts for the balloon, for the drug entrance. But this is something we don't know how much more we do than compared to other balloons. But the concept is really to undersize the balloon, the Wolverine, and sometimes it works, and honestly, sometimes it doesn't. Sometimes it just dissects, and then you have to put a stent. But very often it works, and it works more and more and more with time, because we learn and become better.
Maybe let me just add one more point there. I think there is that recommendation from this consensus paper, which has recently been published in JACC Interventions by the consortium of interventional cardiologists focusing on drug-coated balloons in PCI. And they actually recommended there to size 1-to-1 for lesion preparation and drug-coated balloons. And I personally strongly disagree with that approach. I would rather use intravascular imaging, either IVUS or OCT, to measure first and then decide about your strategy, rather, as Florim just mentioned, rather downsize your balloon and upsize the pressure and crack the lesion first. And to be honest, what you didn't mention there, we're not too afraid about dissections because there are many ways to handle them afterwards. And therefore, but as Florim mentioned, don't oversize the balloon at the start, because then you've got a problem. The dissection might spirals down, and you have to end up stenting the whole vessel.
And importantly, Matthias, also you mentioned it, I think, intravascular imaging. I mean, Abbott is very happy about us, but because we use so many OCT catheters with this. And I think this is also important because we size our balloons according to OCT. And I think this is also important. So treating patients with drug-eluting balloons is expensive, but it's good quality. It's not cheap. If you want to have a cheap system, then you don't use this because, of course, the cost for PCI is higher because you use more intravascular imaging, in our case at least. Then you use the drug-eluting balloons are more expensive. The lesion preparation becomes a bit more expensive because you are, but I think it pays off because if you creating a full metal jacket will maybe be cheap in the short term, but expensive in the long term.
May I ask just one question, because this concept is very interesting for me. And if you create this section, right, open the artery widely, there are some cases, for sure, there must be one or two cases when you have to stent, for example. And tell me, because you always do OCT in these cases, and when you decide to leave and when you decide to stent?
That's a very good question. The problem is OCT will not help you make this decision because OCT will create more uncertainty because on OCT it will look very ugly. And I think this is, and I think that's why I think I use the OCT much more for the lesion preparation, sizing the balloon, understanding the lesion, rather than deciding if I should put a stent or not. We decide angiographically, and by, of course, patient pain, ECG, and we decide on a consensus basis. So we are 3 guys in our center doing a lot of drug-eluting balloon use, and usually we show the result to each other and say, would you leave this? And if you have a 2-1, then you leave it. If you have a for leaving, if you have a 3-0 for stenting, then you put a stent. But this is a rather, I think I'm not there yet to be very robust and say, okay, leave it. But when I saw yesterday, what Colombo left in that live case, I have to say, I have to leave much more. Okay, so let's continue. Now we will hear Dr. Matthias Possart. He's a senior interventional cardiologist in Lucerne and also a very skilled operator. He likes to do a lot of CTOs, and since some years he likes to treat CTOs with drug-eluting balloons. So let's hear what cases he has prepared. Matthias, please.
Thank you, Florim. Thank you very much for the nice introduction. And for the, I've actually prepared a little bit less illustrative presentation than you just had, but I hope I can convince some of the attending audience or cardiologists to more frequently use drug-coated balloons in cases with CTOs in the near future. And I'd like to give you some content, provide you some insights which are important if you manage patients with drug-coated balloons who have CTOs. Okay, I'd like to start with a brief case vignette. It's a 50-year-old gentleman who has a history of a chronic coronary syndrome who has actually been treated by Florim. He had a history of PCI to the LAD and RCA 7 years earlier. Here on the short angiogram, you can appreciate that he had a stent in the prox LAD, which wasn't too bad at that time. And actually, he presented to our side with progressive shortness of breath and some mild angina. And on the angiogram, we figured out, or actually Florim figured out, that he had now occluded mid-LAD, as you can appreciate here on the angiogram. And the question actually comes up, how would you manage that? And we might discuss that a little bit more later. And I guess most of you can already appreciate how we manage that. Okay. But to give you some context, first of all, you need to be what do you need to know about CTO lesions? CTO lesions actually represent a growing case burden to all the cath lab globally, and in fact, approximately 20% of all patients who've been referred to for angiography have CTOs. More so in patients who present with who have been dealing with diabetes or heart failure. There, the prevalence is even higher. There has been some registries. Registry data which showed that up to 40% of all patients have CTO lesions. And more importantly, that the prevalence of CTO lesions increases with advancing age. And the symptoms which most of those patients have are actually not just angina, but the majority of those patients present with shortness of breath and exercise intolerance. And there's also still a limited adoption of CTO Pci, and since many interventionalists still feel afraid to conquer those lesions or don't feel comfortable to treat them, and many CTO lesions remain untreated, or patients with CTO lesions are still unnecessarily sent for CABG. And with the advances in techniques and materials within the last decade, and also the increased operator experience, the success rate of CTO PCI has tremendously evolved, and expert CTO operators now have success rates beyond 90% up to 95%. And I'm sure that those rates will further increase in the upcoming next years. The question is actually, why should we treat the CTO? As we know, there is conflicting data, and there has been just recently a trial called Ischemia, which brought some discourse to the whole topic. But the reality is that many patients suffer despite optimal medical treatment, and CTO PCI has been proven to be effective for symptoms management. It also has been proven to improve LV function, and also it has some consequences for future ACS presentation, meaning open arteries prevent patients from worse outcomes if, in case they have a concomitant, an ACS in the future. And also it has been shown that patients who had undergone CTO PCI have a lower risk for ventricular arrhythmias, and by doing CTO PCIs you might defer a CABG procedure. And down there, as I mentioned, CTO patients might use less nitrates or less meds in the near future. And the reality for us as interventional cardiologists is, you, on one side, you help the patient, but you also improve your PCI skills over time. So basically it comes down to that you always have to wiggle the pros and cons of sending a patient to a PCI procedure. You always need to well inform the patient about potential periprocedural complications, but you also, and that's actually important here, it's a very nice paper which has recently been published, and you also should inform the patient about the increased risk of target lesion failure down the road, because it's still a reality that patients who undergo CTO PCI with stent implantation have a higher risk for stent thrombosis, but also restenosis in comparison to common or more simple PCI procedures. The outcomes of patients who undergo CTO PCI with contemporary drug-eluting stents aren't that bad, but there is actually quite a bit of room for improvement. This is that's the data from the recently published expert CTO trial. It's a multi-center trial which assessed the performance of an everolimus-eluting stent in patients who undergo CTO PCI. And I picked this slide here to highlight how high the target vessel failure rate is in those patients and those are the outcomes after 1 year. And you can see there has actually been a target vessel failure of up to 16%, which I consider very high. And that's a signal which has been reproduced by other studies as well. And we need to take that into account when we manage patients with CTO lesions and contemporary drug-eluting stents. The pathological hallmarks of CTO lesions include the 7 following points. Those lesions have usually a high burden of atherosclerotic plaque. They have a tough fibrous cap, which also often is very calcified, and they have a softer part in the middle section of the lesion, and those calcification and fibrotic parts increase with advancing age of the CTO lesions. CTO lesions are usually very long. They're longer than 30 millimeters, and the vessel distal to the lesion is usually diffusely diseased, and the vessel size at the distal end of the lesion is actually collapsed, and you can't really appreciate the full extent of the vessel. And what we also need to take into account that CTO lesions usually lead to a slower and thinner endothelial coverage of stent struts once those lesions have been treated with contemporary drug-eluting stents. And that's actually important if you think about long-term outcomes of those lesions after stent placement. So basically, the consequences which we should take into account after treating a CTO lesion with PCI is that, what I just mentioned, that those lesions are long. Therefore, we would have to place a long stent, or those lesions actually tend to positively remodel once you've opened up the vessel, meaning at the time point once you open the vessel, the distal part of the vessel will actually not have its final size, and this actually makes stent sizing very difficult, and it often leads to malapposition or undersizing, and this directly leads to the question: is there actually that's actually the room where drug-coating balloons could be very helpful in those lesions. And also, often you have to place drug-eluting stents in in an extraluminal room, which also limits appropriate sizing. And there's also the question if that's an option to use a drug-coating balloon there and not having a stent, which ultimately ends up being malapposed and undersized. As you're well aware, there's a growing body of evidence for using drug-coated balloons in coronary artery disease. That's the just recently published long-term outcomes of the basket small study. In that study, a paclitaxel-eluting balloon has been compared to the Taxus and Science stents, and it showed non-inferiority of drug-coating balloons in small vessels. And those results have been reproduced, or actually other studies have pointed towards similar directions. But what we need to take into account that in those studies, or especially in the basket small study, CTO lesions actually have been underrepresented, or in some studies, CTO lesions have been an exclusion criteria for the use of drug-coated balloon. So But the reality is, if you think about this and from a logical standpoint, there is actually a lot of potential for drug-coating balloons in CTO lesions. First of all, you leave the vessel uncaged, as I just mentioned. After CTO PCI, the vessel tends to grow over time. We now have some evidence for DCBs in especially small vessels. So it's logic that those findings or those results could actually also be translated to CTO lesions. By using a hybrid strategy, meaning combining drug-coating balloons and drug-eluting stents, maybe just use a drug-eluting stent at the occlusion site or at the site where you deal with a very calcified lesion, you could actually spare some stents and prevent unnecessary stent placement. Over time, also, this allows to keep the duration of dual antiplatelet therapy shorter, and we also need to take into account that by not implanting stents, you mitigate the risk for late stent thrombosis, which is still a concern with contemporary drug-eluting stents, especially after managing chronic total occlusions. We've been using various drug-coating balloons in CTOs for quite some time now. That's an abstract which we've are going to publish hopefully soon, and we've collected the 61 most recently treated patients who have undergone CTO PCI at our site, and we found that 47 of those cases have been treated with a SELUTION drug-coated balloon. The average, the mean JCTO score wasn't that high; it was just 1.8, and those patients have a follow-up for approximately 6.7 months now. But the results are actually what I consider quite promising, and we found in those lesions or in those cases that only 3 patients had a target lesion failure, whereas only 1 patient was actually symptomatic and required urgent management, and we had no acute vessel closure. And those were actually, so as you can see here on the right side, because some of those lesions were rather long, and we used an at per average more than 2 drug-coated balloons. And therefore, I think there is actually quite some room for use of drug-coating balloons in CTO lesions, but there is still, again, room for improvement, and we need to learn some more how to prepare those lesions and in which situations we need to use a hybrid approach or where we should actually avoid use a stent. This approach or using drug-coating balloons in CTO lesions hasn't been just done by our site, but other sites. There have been quite a few publications. Most of them are smaller studies, single-arm studies, registry data, or even retrospective data. That's a publication which has been published in International Journal of Cardiology. It has been published by a German group, and they actually analyzed 34 patients who have been treated with paclitaxial eluting balloons. And I picked this study because I was actually a bit astonished when I saw the high rate of restenosis, which was up to almost 12%. And then when I looked into the data, I realized, or I noted, that they haven't been using appropriate lesion preparation. And therefore, I'm convinced if you prepare the bed well, or if you prepare the lesion well, that you can actually improve your outcomes, and you can achieve similar results as we have found in our small registry so far. So by moving on, as Florim mentioned, and I would say I absolutely agree, and we are in line in that point. If you use DCBs, irrespective of the kind of lesion you manage, and more though in CTOs, it's key to vigorously prepare the lesion. So as I always like to say, use intravascular imaging if possible, use dedicated tools, use true non-compliant balloons, avoid semi-compliant balloons. If necessary, use cutting balloons, scoring balloons, rotor, shockwave, but invest a lot in lesion preparation. And as Florim mentioned, crack the calcium, downsize the diameter, upsize the pressure, and don't be afraid of dissections. There are several ways to deal with them. You can actually tuck them by using prolonged balloon inflations with the DCBs, or if necessary, just use a short stent to cover it. And on the right side, you can see the recommendations from that consensus paper, which I just mentioned earlier, and they're recommended there to use standard semi-compliant balloons for Dcb Pci. That's something which I strongly disagree or not encourage at all. And also, I'm not so keen about the balloon to vessel ratio of 1:1 for lesion preparation. Would be there a little bit more conservative. And but basically, if you're once you've treated the lesion and actually you don't have a flow-limiting dissection or a residual stenosis of less than 30%, I'm very comfortable that the vessel will stay open. Okay, now coming back, as you're well aware, we decided very early in the course to avoid the stent because we were well aware that's a very long lesion, and by using a stent, you would actually omit cabbage for this rather young patient at any point down the road, and therefore Florim actually treated that patient very well or very nicely with 2 drug-coating balloons and achieved a very nice result. Here you can see the final angiogram, and here you can see on the right the 4-month follow-up. And as okay, I apologize for the background noise. Okay, and now I'm coming to my take-home messages. CTO hallmarks, which you need to be aware of. Those are lung lesions, fibrocalcific caps. They have a softer body in the in between, which actually allows very nicely to treat those lesions with drug-coating balloons. DCB and CTO, adequate lesion preparation is key. Early data from our side and other studies implicates feasibility and safety of DCBs and CTO lesions, but certainly there is room for more data. And actually, there's actually already there has a study being launched, a randomized trial for use of DCBs, contemporary DCBs in CTO lesions, and I'm keen to learn more about that technology in the near future. Thank you very much for your attention.
Thank you very much, Matthias. Maybe there is some questions from the other people who don't work with Matthias, because I see him every day and can ask questions every day.
Fantastic. That was a great presentation. Obviously, the role of drug-coated balloon is expanding and it could be applied to complex lesion. So my question is, in chronic total occlusion, the study you presented, are they consecutive patients, or you decide on the drug-coated balloon after the balloon result? Would you like to comment on that?
Let me just go back. So from our registry, we're actually those were consecutive patients who have been treated with CTO cases. We've been treated with DCBs at our site. Basically, Florim, please correct me, but I would say nowadays, whenever we do a PCI, we have in mind that we could basically use a drug-coating balloon, irrespective of the vessel size, if it's not a STEMI. Whenever possible, I've stopped using semi-compliant balloons for lesion preparations many years ago, or actually once I've arrived in Lucerne. And now over the last 2 years, whenever I do a PCI, I actually aim for use a drug-coating balloon. I think Florim agrees with me on that. He has a similar approach. First, and therefore we basically always use non-compliant balloons, do aggressive lesion preparation, and also in situ lesions it's the same. Like whenever possible, we would aim for use of a drug-coating balloon.
Yeah, I mean, maybe I can add. So the good thing is that, and this is the mindset which has changed by also seeing this long-term or longer-term results after 4 months, 5 months, 7 months, 8 months. We see the angiograms and we see how this is working, because in the beginning you don't have the confidence that this is going to work for your patients, but now we have. So whenever we see a patient, we always discuss, can we treat this with drug-eluting balloon only? That would be ideal. Or can we do a hybrid case? So sometimes we are disappointed that we just put only stents and don't use a drug-eluting balloon. But this has changed. I mean, 1 year ago, this was not, this has changed with SELUTION, I have to say, because we see those results which give us the confidence to continue on this journey. And the great thing also is that by learning from each other, by showing the case to each other, this is also, because if you just put stents every day, one day it becomes boring. So now for us, this has opened a new challenge in our daily life. And besides other things which are also challenging, but this is something new. So I think I would whenever maybe trips to our lab can be organized to see us and work with us, and maybe we will do some workshops also with Med Alliance. We already do with CIS Medical. So and come and see us and discuss. I like this interaction. This is why we are here and trying to exchange our experiences. So for the sake of time, maybe we have to continue. Now I have the great pleasure to introduce Professor Bartusç from Krakow, and he will speak about something interesting, and I'm really keen to know how he is treating bifurcations with drug-eluting balloons. Please, Stanislaw.
Thank you, Florim. Matthias, could you stop sharing screen, please? Because okay, thank you. Okay. Thank you very much for inviting me for this meeting. I would like to say a few words about the drug-eluting balloons in coronary bifurcations. Coronary bifurcations are always the challenge. And excuse me, are you seeing my screen normally or with some green?
We see it's it's a bit cut, I think, in the top and bottom part.
All right, so I will stop share and do it once again, maybe, because there must be something wrong. Okay, maybe in this way. Okay, now it should go as well. All right, so we have two concepts of use of drug-coated balloons in the bifurcations. One is use two drug-coated balloons, and avoid using the stent. And the second is some kind of utilization of European guidelines for the bifurcation lesions, so the provisional side branching stenting, but with using the drug-coated balloon in the side branch. So these are two very nice concepts, and for me, the use of the drug-eluting balloons in the bifurcation give us several advantages. Of course, first of all is local application of the drug for the short period of time, avoiding the chronic inflammations from stents or from polymers, and of course preserving the original vessel anatomy. But for me, the most important is avoiding the double or triple metal layers that are usually done by us during the two stent techniques. There are many studies using the drug-coated balloons in bifurcations. However, I would like to describe shortly some of them. First is the PEPCAP study, which bifurcation study, which avoided using the stents. And this study showed that the binary restenosis grade was very small in comparison to the plain balloons, reaching no more than 6% of the restenosis in bifurcations. It was driven mainly by the very low late lumen loss. So that study was positive. However, it was very, very small study. Again, additional small study, observational study, including 70 patients. And this study shows that very low number of MACEs, 6.1% of MACEs in 9 months follow-up, with target lesion revascularization reaching 4.5%. So again, very nice observational study. However, it was statistically negative. The second concept using the drug-eluting balloon for the side branch only was tested in this study, and this study showed that the total MACEs was half only in comparison to the plain balloons. The need for target lesion revascularization was also smaller. However, statistically, this study was negative. So, because all these studies were very, very small number of patients, including small populations of the patients, there was done a very nice meta-analysis of 4 studies, including almost 350 patients, including 3 randomized trials and 1 observational. And this study clearly showed that in all of these studies, we can see that there is definitely lower number of side branch binary restenosis, and the number of MACEs and target lesion revascularization was not statistically significant. And this study is showing only that the concept of the using additional stent in the restenosis of the left main is a bad concept, because you are making only the stent sandwich, and this concept was showing that these patients are dying if you put them additional stent in the restenosis. So current guidelines for the ESC guidelines do not recommend to use the drug-eluting balloons in the side branches. Also, the European Bifurcation Club do not recommend it, because, as I said, the data are not so conclusive. There are small studies, including small population of the patients, and there are many questions in regard to the technique of the bifurcation treatment. And this is why they completely do not recommend the use of drug-eluting balloons in the bifurcations. American people do not have guidelines, but in the JACC they published the so-called state-of-the-art review. And in this state-of-the-art paper, they published and they showed that there are also mixed results in treatment of the bifurcation lesions. However, they recommend to use trying to use the drug-coated balloon in the side branches, because they believe making the suggestion from these studies that it might be nice idea. So this is a study from China which showed that there is a positive result in the using the drug-eluting balloon in the side branches, because you have the smaller number of the late lumen loss, and the cumulative frequency of the smaller minimal lumen diameter in the side branches is better in the patients treated with drug-coated balloons. So coming to this technology that we are describing today, I would like to say that this technology brings several advantages over the balloons that we've been using in the previous times. John described it very well. I do not want to repeat it, but I would like to stress that this electrostatic cat coating and this new biological biodegradable polymer that is carrier delivering the drug to the tissue is giving a new landscape of the using the drug-eluting balloons in the side branches, and it is supported by the very nice results brought by the Stefan Windecker. So this is our concept of the use of the drug-coated balloon in the bifurcations. This is the patient with the critical lesion in the LAD. This is in fact acute coronary syndrome. Patient is 44 years old, young patient with nice critical lesion with troponin more than 2000, and the patient has a pain. So in our cath lab, we decided to use for the planning of the procedure the new Ultron software, which let's say facilitate the usage of the OCT in the cath lab, and gives you information about the distal reference of the artery and the proximal reference of the artery, and also can facilitate for you the length of the stent. In this patient, we decided to use the stent no more than 23 millimeters, and the proximal reference was 5.2, maybe 5.5, and the distal reference, maybe it is, and the distal reference was 3.5. So this is the stenting procedure with the stent, and then we did a kissing. We did a pot first, and then we did a kissing, and the kissing was done with the sirolimus eluting balloon, and the post dilatation of the LAD was done with a high pressure balloon with 30 atmospheres. So as you can see in the OCT, the result in LAD where we used the very high pressure balloon was very nice. There is completely no opposition. The expansion of the stent is proper, but in the left main, the machine found that the expansion of the stent is only 76%. So we had to post-dilatate with a bigger balloon in the left main, and we showed, too fast, and we showed that the final result was very nice, reaching about 80 and more % of the stent expansion. So this is our concept, how we believe that the bifurcation should be treated. Of course, this concept need further investigation, further studies. However, I believe that not all the bifurcation can be treated with drug-coated balloons only. But of course, we don't have the good recommendation of ESC or Bifurcation Club for the use of drug-coated balloon in the bifurcations. However, I believe this concept will bring the drug-coated balloons to the bifurcations, and maybe the next stage will be using the drug-coated balloons only in bifurcation lesions. Thank you very much for your attention.
Thank you very much, Stanislaw. So I'll ask now Matthias Possart to maybe comment on your talk. Matthias, should we do it like Stanislaw, or what do you think?
Actually, it was a very thank you for it was a very nice presentation, and I really loved it. And again, like I think I was a little bit surprised how conservative those recommendations from the bifurcation clubs are in terms of use of DCBs in bifurcations. Again, like from a logical standpoint, it just makes absolutely sense to use DCBs in those cases as much as possible, because you avoid or omit placing a second stent in a bifurcation. And to my best knowledge, as far as I'm aware of the contemporary data, like by using a simple strategy and use only one stent, you still have the best outcomes. Isn't that what we've learned from all studies so far? And therefore, I'm sure that future data will tell us to even more use DCBs in bifurcation lesions.
Yes, I
like
believe,
to hear what the rest of the group thinks.
I believe that we still don't have strong data, and as you probably noticed in the Bifurcation Club document, there is no Antonio Colombo or Florim Cuculi. There is Francesco Burza, and he is probably, of course, giving the recommendations. You need very strong data. You need very strong data from randomized studies, and we have to understand that these recommendations has to be conservative, because the recommendations must be resistant for the potential mistakes that can inexperienced operators do. So this is my feeling how to create the recommendations. So this is why probably they completely not showing anything about drug-eluting balloons. However, the concept of use the drug-eluting balloon in the side branch maybe is not so well proven. However, if you are treating the left main, if you are treating it with provisional stenting, the best concept of treating the left main, and you are touching the circumflex artery with a balloon, especially in young patient like this 44-year-old patient, you think that maybe I will provoke the restenosis in this circumflex, and maybe he will need additional treatment in the future. So why not to prevent it with the drug-coated balloon? This is my way of thinking in such cases.
I think, Dr. Bartusś, that we've been approached by Yves Bossard, who is a past president of the Bifurcation Club, and he has been talking to us about some proposed studies that they would like to do of using a drug-coated balloon in the side branches. It's going to take an important trial to be done really to make it something that I think the Bifurcation Club could come out with a new recommendation. And it's just a matter of time before that trial will be done. I don't know how or who's going to do it yet, but it's certainly something that's being actively considered.
Well, actually, just today I received an invitation from the Bifurcation Club to join a meeting in Brussels, I think next month, where they want to discuss exactly this topic. So drug-eluting balloons in bifurcations. I think, and the idea was Yves Loubart wrote that they want to propose a new trial, a randomized trial. So I think it's going in that direction. I think we need more data. So maybe for the audience, if you have written some questions, I've seen them, and we will answer them at the end of this webinar. But now, without further ado, let's hear a very good speaker and good interventionist from the UK. Dr. RATHORE will speak about something very interesting, and I'm very keen to hear now how he treats complex lesions and bifurcations in the UK. Thank you very much, and please.
Thank you, Florim, and thank you, other panel members. A very interesting talk. So I'll start to share my screen now. Can you see my screen? Right, okay, so I'm going to talk about, obviously, as the theme is drug-eluting balloon, or you call it drug-coated balloon, so my emerging role of drug-eluting balloon in complex coronary bifurcation. So I will be sharing with you my take on this and how I treat bifurcation and use drug-coated balloon at my hospital. So not all side branch or not all bifurcations are important. So I think the concept is that you need to treat a bifurcation, true bifurcation lesion with an important side branch. So there's a concept of fractional myocardial mass or the myocardial mass supplied by a specific vessel. So it can be calculated by different means, and larger the mass supplied by the branch, maximum is the benefit. So if you see here, the left main bifurcation more or less supplies the large quantity of myocardium and is an important side branch. If you see this study, which was done a few years back, only 1 out of every 5 non-left main side branch supplies myocardial mass more than 10%, which is important. And mainly they are in the diagonal territories or a large obtuse marginal territories. So it's very important to know which bifurcation we're talking about. Now, if you look at historical, I don't want to dwell too much into the studies. The speaker just spoke before me, a professor, has already discussed the studies here. But if you see here, the main difference between provisional and 2 stent in the bifurcation is there's a higher incidences of target lesion revascularization. As you can see here, 4.3% in DK group compared to 13% in the provisional group, and most of these restenosis or the TLR are from the side branch. Similarly, if you look at left main provisional, DK crush versus provisional, here also the TLR rates were high, and mainly the MACE rate and the 12-month MACE rate were driven by high target lesion revascularization. If you look at DK Crush 5, the study that the incidences of restenosis, the majority of the restenosis in the 2-stent group also, not in the DK Crush group, but in the provisional arm who needed stent, or in the provisional group, are at the side branch ostium. So side branch ostium is very important in true bifurcation, and majority of the TLR are driven by target lesion revascularization at the side branch. So if we can achieve a good result at the side branch by either balloons or by the drug-coated balloon, I think the outcomes will be good, but this still needs to be proven in a large randomized trial. Similarly, if you see in definition 2 trial, the difference between provisional group and the 2-stent group is mainly, if you see here, target lesion failure 11.4% versus 6.1% so this 11.4% can be brought down to about, say, 50% reduction with drug-coated balloon, hypothetically, and then the target lesion failure between 2 stent group and 1 stent group with drug-coated balloon at the side branch will be more or less similar, and the benefit will be there will be low late stent thrombosis and low incidences of other major adverse cardiac event. Now, I want to skip these, which my colleagues have already discussed, the effect of drug-coated balloon only in bifurcation lesion, which gives a pretty good result with target lesion TLR rate at 4.5%. And this is the study looking at the treatment of in-stent restenosis after 2-stent strategy in coronary bifurcation. You can see here, majority of the restenosis are at the side branch, 66%, with a good result achieved with the drug-coated balloon, as you can see here. Similarly here, this is a comparison of clinical outcomes after drug-eluting balloon at left main bifurcation in-stent restenosis, and the data with drug-coated balloon is much better than the drug-eluting stent in the long term, as you can see here, which was very nicely demonstrated by my colleague. So summary of DCB data, what it shows here that the studies have shown feasibility of drug-coated balloon can be used for de novo bifurcation lesion. It has shown reduced side branch restenosis and TLR, potential of reduced major adverse coronary event and stent thrombosis, and the advantages are shorter dual antiplatelet treatment, and this seems to be an attractive option, and there is no class effect as we have seen. So I will now share with you some cases where I have used drug-coated balloon and particularly SELUTION in my last 2 cases. So this is one of the case. You can see here the ST elevation MI case presented with the anterior STEMI, and this is the result I achieved after the aspiration thrombectomy and drug bifurcation and the balloon stenosis. So you can see here on the left-sided panel here, after the drug-coated balloon, if I go back here, after the stent implantation to the main vessel, there was a severe residual stenosis in the side branch, which is a large branch. So I dilated that and treated the side branch with a drug-coated balloon, as you can see here. And after the drug-coated balloon, this was the result, which achieved a good result. Residual stenosis in the side branch was less than 50% with good flow in this branch. And then we got this patient back in 6 months' time, as you can see here. The proof of the pudding is in the eating. As you can see here, majority of the time after 6 months, it was giving a good ongoing result in the side branch after the drug-coated balloon. Another case you can see here, this is a left circumflex 011 Medina bifurcation lesion. So what I did here, treated this with a crossover stent across that large marginal branch. There is a severe side branch lesion after the drug-eluting stent, which is more than 70%. I crossed it with and treated it with first across the stent with a wire, and then treated with opened the stent stud with the non-compliant balloon, and then treated it with a drug-coated balloon in the side branch, followed by kissing balloon with the drug-coated balloon and another balloon into the main stent, and following report, this is the final result. And this is the follow-up angiogram. At 3 months' time, you can see it gives a good ongoing result, and the side branch ostium looks pretty good. So all these cases, there's another left main stem case here. We have got a 111 lesion. As you can see here, there was about 70% lesion in the side branch of the ostium in the circumflex. I decided to treat it with a crossover stent from left main stem to LAD, followed by drug-coated balloon after recrossing with the wire into the circumflex ostium with a non-compliant, with a semi-compliant balloon, followed by drug-coated balloon, followed by kissing balloon. And I used the same balloon, the drug-coated balloon, and this was a solution in this case, followed by report, and this was the final result I achieved here with a good ongoing result in the circumflex ostium. And this is a 6-month follow-up in the same case. You can see it gives a good ongoing result. The left main stem looks good, the side branch looks good, and the no restenosis seen. So this is my last case. If you see, this is a trifurcation case. The stenosis is severe in the left anterior descending ostium, extending into the left main stem. So I treated this with a crossover stent from left main stem into LAD. And following the stent, the side branch, which is, you can call it a high intermediate or the circumflex, there was some plaque shift and the side branch stenosis was more than 50%. And we treated the DCB to the both intermediate and the circumflex ostium. And this was the final result after the kissing balloon we used with the same balloon. As you can see here, we used 3 balloons to open up and followed by report. And this was the final angiogram, which achieved pretty good result in this case. And this was the final angiogram. You can see the good result in the left main stem, ostium of the left anterior descending coronary artery, and good ongoing result, and the good result in the intermediate or a high OM1 and the left circumflex. So obviously, just to compare the pharmacokinetics and desirable properties, what we need in drug-coated balloon, as you can see here, we have got now second generation Limus eluting balloon, which is a solution, and it has got most of the properties we need. Elution control is good. There's no coating, and nature of drug release is novel, and it can be retained in the vessel wall. Now, these are some of the things which we have recently published. What are the potential targets and measures to improve outcomes with DCB? As my colleagues here have shown, that the lesion preparation is very important. So these are certain factors. So non-compliant balloons should be used. Cutting balloon and scoring balloon along with plaque modification should be done prior to using drug-coated balloon, so that you can achieve good expansion of the lesion and then good drug delivery into the vessel wall to achieve good results. And obviously, we need to get some new trials and data to prove this hypothesis. Now, this is one of the things we have proposed, bifurcation with large side branch, more than 2.5 millimeter and significant myocardial supply. I usually wire both branches, dilate the main vessel, and put the drug-eluting stent followed by pot. After that, if the residual stenosis in the side branch is more than 70% for non-left main stem, or more than 15% for left main stem side branch, or the FFR is less than 0.8, or the TIMI flow is low, then I decide to treat the side branch. And then, and if neither of these things are present, then we stop after report. No further action is required to the side branch. If the residual stenosis in the left main is more than 50%, side branch more than 70%, I usually cross the side branch, dilate the lesion 1-to-1 with a semi-compliant balloon or the non-compliant balloon, followed by treatment with drug-coated balloon, followed by kissing balloon with the drug-coated balloon and the other non-compliant balloon into the second branch, followed by report. And the second vessel is treated in a provisional fashion, a side branch, and I treat it with another drug-eluting stent if there is residual stenosis more than 70 to 90%, or if there is a flow-limiting dissection, then obviously there are options available, as we suggest in the EBC as well, to use either TAP, T, or reverse crush or culotte can be used. So in conclusion, gentlemen, I would like to say drug-coated balloon to the side branch with provisional stenting is an attractive option. And this is my default strategy now for most of the true bifurcations with live side branch, and it allows good drug application and restoration of normal anatomy and carina. And optimized side branch preparation, I believe, in true bifurcation lesion would potentially reduce the MACE events in TLR, and it needs to be proven in a randomized trial, which the Bifurcation Club is planning to achieve now. And the reduced bailout stenting to the side branch by good lesion preparation, as shown by our colleagues from Switzerland, that you need to prepare the lesion well, 1-to-1 with no dissection. Randomized trials are required, and there is one of these trials proposed as the EBC Pro-DEBT study is in the pipeline, and the other options are also being considered to do a bifurcation, true bifurcation lesion with drug-coated balloon. Thank you. I'd like to stop, and I'm happy to take any questions.
Well, thank you very much. Very, very interesting cases. I especially liked that left main bifurcation. I'm sure Dr. Possart will now replicate it tomorrow. I have one question. When you use the, you use the drug-eluting balloon for the side branch, and then you do the kissing afterwards. This is a question for you and maybe also for John. Are we confident that we are not pushing drug away by repeatedly inflating the balloon in the same lesion after you have applied a drug-eluting balloon? What do you think?
Well, I think John will be able to comment. What I would like to comment, because we go with the philosophy of if it is obviously if it's a complex bifurcation lesion, I will do a little pre-dilatation to the side branch prior to putting a main vessel stent, or will do a provisional strategy. And after that, if the side branch looks good, I will leave it after report. If the side branch needs treatment, then I will recross, dilate with a small balloon the stent strut, because it's difficult to cross the drug-coated balloon through the stents. And after dilating with, like, say, if it's with like 1-to-1 balloons, then I cross, and I have not had any problem so far, and I have treated at least 40 or 50 cases with this kind of drug-coated balloon through the stent strut, and then I use the same balloon to apply to do the kissing balloon, basically, not recross. Now, I don't know, I've not done any prospective studies or histopathological studies, or I don't know how to look at the concentration of the drug at the side branch. Usually the results look pretty good, and majority of the patients I've got a follow-up which looks good, good side branch, and it's not caused any damage. So I would love to hear from John about the pharmacokinetics and whether there is any damage to when we cross through the stent strut drug-coated balloon. Is there any potential for damage to the lining, release of drug, or any problem there from his point of view?
And John, maybe just also with this question, an additional one. Sometimes when you apply a drug-eluting balloon, then we tend to do a prolonged balloon inflation after this if we see a major dissection, to just be able to just seal the dissection, and we inflate the balloon again in the same lesion where we apply the balloon. Are we confident enough that we are not damaging the balloon, the drug delivery to the vessel? John, please.
Yeah, thank you, Dr. Cuculi. First, I want to comment. Wonderful talk, Dr. RATHORE. I think you have developed a new technique, at least in my experience, which I'm going to dub triple kiss. I haven't seen that used before in trifurcation, but it was rather stunning to see such an amazing thing. And I have one question regarding to that. Have you ever seen, when you're doing these kissing balloons, in the case of using, let's say, 2 drug-eluting balloons, especially solution, have you ever seen the pumpkin seed effect where one balloon will spring forward or back? I would ask you to comment whether you think there's any practical aspects of doing kissing with 2 balloons that people need to be aware of when they do this procedure. I'm curious myself how you experience that. In response to your question about Dr. Cuculi about second or long inflations of drug-coated balloons, the drug is, because of the nature of the cat coating, it's effectively transferred within 30 seconds. If you continue to keep the balloon inflated and opposed to the vessel wall, this certainly won't harm anything. The coating has already been effectively deposited to the vessel wall, and it won't be damaged. The coating will be retained once the balloon is ultimately deflated. So longer inflation time won't really affect the efficiency of the drug transfer. Is very fast, and so we don't need long inflation times. And in fact, long inflation time really won't increase the amount of drug delivered because of the ability of the cat coating to effectively become established and docked to the vessel wall in the first 30 seconds of the procedure. I hope that answers your question.
Yeah, it does. Thank you very much. And now I have some more questions from the audience. It has been a very interactive session. So let's see. One of question is from Bogdan Janusz from Poland, who asked how long we use double antiplatelet therapy after solution. So maybe Matthias Possart can comment on this. How long DAPT after solution?
How long adapt? Okay. Usually, there hasn't been any randomized study yet, but what most publications and consensus papers recommend is 1 month. But basically, if you use, especially if you use a hybrid strategy, you would use a longer approach, 6 months up to 12 months in an ACS, or maybe in a high-risk bleeding patient, even shorter, 1 month also in a hybrid approach. But basically, that's I'm going to tell you how we usually handle it in complex lesions. As I just mentioned, is CTO lesions, we would usually keep the DAPT duration a little bit longer. I personally like to use potent antiplatelets for a short duration, because especially as mentioned at the beginning of that session here, you have a lot of platelet activation, and I think the patients benefit from aggressive antithrombotic therapy at early beginning after PCI, and then after a few weeks, once everything has healed nicely, you can actually stop, and I feel very comfortable to stop the DAPT and continue with aspirin after 1 month in the majority of my cases.
Thank you very much. It's interesting that if you don't have a stent, you cannot have stent thrombosis. So we have treated now hundreds of patients. I don't know, you know better, maybe 400, 500 with solution, and we still haven't seen an acute vessel closure with this, which is also, I think, an important point. Especially imagine if you have to decide whether you leave the lesion like that. I think if you left stent lesions like we leave balloon lesion, they would all close. But with the balloon, because there is no stent, you don't have a stent thrombosis. Now, another question, and this is maybe a question for Stanislaw, Bartussz. Tell us, how long do you leave the solution? This is a question from the audience. How long do you leave the solution inflated for optimal delivery of the drug?
According to the company, you should use it for 30 seconds, no more. However, there are many, from my experience from the peripheral interventions, I can remember that we've been using the inflated balloons for 7 minutes and longer. Of course, the cardiac patient is not able to still be alive after so long inflation of the balloon. So we have to follow the instructions. So we do not, especially in the left main, if you go with the kissing balloon or inflation in the circumflex artery, you should just go for 30 seconds according to the company instructions.
Thank you very much. So these were all the questions we had here. I would like to thank every one of you for participating here, the speakers. It was great talk, great interaction, and I hope we can do this again, because the interest was so big. As I hear, there were over 100 people watching constantly, and this is very good for a webinar. Imagine we would do this live in Lucerne, it would be 500 people live. So we would maybe we should do this. And I would again continue to interact with each other. Let's move this forward. I think it's an exciting technology. Let's combine all these tools we have now, these wonderful tools we have to use to treat our patients. Thank you very much, and have a good night, everyone. Goodbye.
Thank you, everyone, and it was a pleasure meeting you people, and looking forward for future collaborations and sharing our